Assalamu alaikum. I am Dr. Refat Tabassum, Associate Professor, Bashundhara Ad-din Medical College, South Keraniganj, Dhaka. Today we are going to discuss about electrolyte and electrolyte balance. What is electrolyte? Electrolytes are the substances that form or exist as ion or charged particles when dissolved in aqueous solution. The concentration of electrolytes are expressed in milliequivalent per liter. 1 gram equivalent weight of a compound is defined as its weight in gram that can combine or displace 1 gram of hydrogen. 1 gram equivalent weight is equivalent to 1000 milliequivalents. The following formula is employed to convert the concentration milligram per liter to milliequivalent per liter. Milliequivalent per liter equal to milligram per deciliter into valency divided by atomic weight of the substance. The monoequivalent ions are sodium ion, potassium ion and chloride ion. 1 milliequivalent equal to 1 millimole, and for the divalent ions, that is calcium ion, magnesium ion, 1 milliequivalent equal to 0.5 millimole. This is the chart which shows the cation and anion present in our plasma, interstitial fluid and intracellular fluid. The concentration of plasma sodium is 135 to 145 milliequivalent per liter. The concentration of the potassium is 3.6 to 5 millimole equivalent per liter. Calcium is 4 to 6 milliequivalent per liter. And in anion we have chloride, that is 98 to 108 milliequivalent per liter. Bicarbonate ion is 22 to 28 milliequivalent per liter. And there are some others, that is organic acid and some proteins. Composition of the body fluids. The marked difference in the concentration of the cation and anion is between the extracellular fluid and intracellular fluid, but their concentration of the extracellular fluid and interstitial fluid are relatively same. The total concentration of the cation and anion in each body compartments is equal to maintain the electrical neutrality. Sodium ion is the principal extracellular cation and potassium is the principal intracellular cation in the anion in the body. Chloride and bicarbonate are principal extracellular anion and phosphate is the principal intercellular anion. Now, osmolality of the plasma. Osmolality is the measure of the total number of the osmotically active particle in aqueous solution. The osmolality of the plasma is 285 to 300 milliosmol per kg. Sodium ion and its associated anions makes the largest contribution of the plasma osmolality. Plasma osmolality can be measured by osmometer. Osmolality of the plasma. For practical purpose, plasma osmolality can be computed from the concentration of the sodium, urea, glucose and R for the for following formula: 2 into sodium ion plus 2 potassium ion plus urea plus glucose. Here the factor 2 is used for sodium and potassium ion for account of the associated anion concentration. As plasma sodium is the most predominant contributor of the plasma osmolality, the above calculation can be further simplified as the following formula: plasma osmolality equal to 2 into plasma sodium ion concentration. Now, regulation of the electrolyte balance. Electrolyte and water balance are regulated together and kidney plays a predominant role in this regard. The regulation of mostly achieved by the following hormones: aldosterone, renin-angiotensin, ADH and atrial natriuretic peptide. Now, renin-angiotensin-aldosterone system. When blood pressure is decreased and blood flow of the kidney decreases, the juxtaglomeralar apparatus of the kidney stimulates, and which causes secretion of the renin, and renin causes angiotensinogen to convert into angiotensin 1, and angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. Now, this angiotensin 2 acts on the renal cortex and causes secretion of the aldosterone, and as well as it causes vasoconstriction of the arterioles. The aldosterone causes salt and water retention by kidneys and increases blood volume, and vasoconstriction of the arteriole causes increased blood pressure. Renin-Angiotensin system is triggered by the reduced stretch of the glomerular juxtaglomerular cells, stimulation of the JG cells by activated macularensa cells, and direct stimulation of the JG cells by a beta 1 adrenergic receptor by renal nerves. Renin acts on angiotensinogen to release the angiotensin 1, which is converted to angiotensin 2 by enzyme angiotensin converting enzyme. Now, angiotensin 2, which causes mean arterial pressure to rise and stimulates the renal cortex to release aldosterone. So, as a result, both systemic and glomerular hydrostatic pressure rises. ADH mechanism. In the ADH mechanism, which is stimulated by dehydration, that is fall of blood pressure, and salt ingestion causes increased plasma osmolarity. Then osmoreceptor of the hypothalamus are stimulated, and which causes posterior pituitary to secretion of the ADH, and ADH causes water retention by kidney, and as well as when we get thirsted, we drink water, and as a result blood volume increases and blood osmolarity is decreases. Now, the action of the atrial natriuretic peptide. Increases blood volume causes increases arterial stretch. Atrial myocardial cells stretches and release atrial natriuretic peptide, which acts on hypothalamus, causes inhibition of the vasopressin. It acts on kidney and increase GFR and decrease renin. Atrial natriuretic peptide also acts on adrenal cortex, which inhibit aldosterone, and it also acts on medulla oblongata, which decreases blood pressure. As a whole, the net effect is increased sodium chloride and water excretion. Atrial natriuretic peptide reduce blood sodium concentration, which decrease blood volume and lower blood pressure. Atrial natriuretic peptide lowers blood sodium ion by acting directly on medullary duct to inhibit sodium reabsorption, and counteracting effect on angiotensin 2 and antagonist to aldosterone and angiotensin 2, thus promotes sodium and water excretion in the urine by kidney. Other factor affecting sodium ion concentration or sodium excretion included glucocorticoid, estrogen, osmotic diuretic, poorly reabsorbed anion, and diuretic drugs. Now, potassium balance. Potassium plays a number of important roles in our body. It maintains the electrical excitability of the cells. It is the major osmotically active solute in the cell. It maintains the acid base balance, and it helps in cell metabolism, and kidney play at the major site for control of the potassium balance. The factor which affecting the potassium distribution between cells and the extracellular fluid includes activity of the sodium potassium pump, acid base status of the body, availability of the insulin, cellular breakdown due to trauma, infection, ischemia, and heavy exercise. The factor regulating plasma potassium concentration are insulin, epinephrine, aldosterone, plasma potassium concentration itself, blood pH, and physical conditions and exercise. Now, plasma potassium concentration. The changes in the peritubular plasma potassium concentration leads to change in the rate of secretion of the potassium by distal tubular cell. Increased plasma potassium leads to an increased rate of secretion into urine, and decreased plasma potassium level has the opposite effect. Blood pH. Acidemia causes shift of the potassium from the intercellular space into the plasma, whereas alkalemia causes shift of plasma potassium from the plasma into cell. This shift causes the change in the internal potassium balance. A very rough guide of the magnitude of this redistribution of the potassium is that plasma potassium may rise about 0.6 milliequivalent per liter for each decrease of pH in 0.1 units. Now, aldosterone. Aldosterone stimulates secretion of the potassium from collecting tubule and collecting duct. the stimulation of the secretion is related to the ability of the aldosterone to stimulate the sodium potassium ATPase activity in the cells of the collecting tubules. In the absence of aldosterone, body potassium content and the body plasma potassium are increased due to a decrease in renal excretion of the potassium. In presence of excess aldosterone, both total potassium and plasma potassium are decreased, and in increase in plasma potassium stimulates aldosterone secretion and decrease plasma potassium suppress it. Insulin. Insulin enhance cellular potassium uptake. The enhanced cellular potassium uptake that results from increased insulin level is thought to be largely due to the ability of the insulin to stimulate activity of the sodium potassium ATPase located in the plasma membrane. A rise in the plasma potassium concentration stimulates insulin to release by the pancreatic beta cells. Conversely, the potassium deficiency may causes decrease in insulin release. Thus, plasma potassium and insulin participate in a feedback control mechanism. And catecholamine. Catecholamines are also involved in the regulation of the distribution of the potassium. Beta agonists lower plasma potassium and alpha agonists increase plasma potassium concentration. And physical conditions and exercise are also involved. Strenuous exertion may do injury of the muscle cells and allow leakage of the potassium into extracellular fluid and causes hyperkalemia. That is all for today. Assalamu alaikum.